everyone. I'm Siri Vaith, Executive Director of the Cystic Fibrosis Research Institute. I'm also the mother of an adult daughter who lives with CF. And on behalf of CFRI and members of our Diversity and Inclusion Advisory Committee, I welcome you to this workshop focused on alternative and complementary therapies in CF care, addressing stigma and improving relationships. This topic emerged during a meeting of CFRI's Diversity and Advisory Committee, with members sharing experiences in which their cultural practices related to health and healing were downplayed or disregarded or worse, and we will hear more about that during this session. Knowing the diversity of our CF community, we wanted to further explore this topic with the broader community, and I really thank all of you for being here today so that we can learn from one another and ideally advance patient-provider partnerships that are based on mutual respect, including respect for patients' and families' practices and beliefs. As always, I want to reinforce that CFRI embraces diversity, inclusion, and equity for all. We know that disparities in healthcare lead to poor health outcomes, and our work to address this is part of CFRI's organizational fabric. As always, I would be remiss if I didn't take this opportunity to share with those of you who are not familiar with CFRI's wide range of resources that we do have many printed materials and video podcasts in English, Spanish, some in Hindi, and we are more than happy to send any printed materials to you in bulk at no cost. We really want these resources that include advocacy toolkits, CF in the classroom, an incredible teen guide, Spanish language newsletters. We want these to reach our community, and those of you who are here who are part of CF care teams serve as the key link. I want to thank the sponsors of our diversity and inclusion program whose support has made this workshop possible, and that includes Vertex, Beatrice, and Genentech. And now, it's my pleasure to introduce today's moderator and panelists. Linda Jenkins of Jenkins Consulting Group will present and facilitate the panel. As a board source certified governance consultant and unconscious bias training facilitator, Linda helps nonprofit leaders create social change. She has provided several very impactful trainings with CFRI over recent years, and we are very honored to have her return to us today. Dr. Hanna Phan is clinical professor and the director of experiential education in the College of Pharmacy at the University of Michigan, Ann Arbor. She's a nationally recognized leader in pediatric pharmacy practice, education, and research. Dr. Phan has developed and implemented innovative clinical pharmacy practice models in ambulatory care, and specifically for those in pediatric and adult CF care. Dr. Phan has presented at CFRI's conference and in podcasts about complementary therapies in CF care, and we are so honored to have her with us today. And Mao Vang is a social worker from St. Paul, Minnesota, who works as a service coordinator with Hennepin County. She's married and has a beautiful, adorable daughter. Mao lives with cystic fibrosis and is a very engaged member of her community. She serves on CFRI's Diversity and Inclusion Advisory Committee. She's participated in CFRI's Diversity Film Project to raise awareness of CF in the East Asian community and beyond. She also serves on our CF Adult Advisory Committee. Mao, we are honored to have you here, and thank you for sharing your personal lived experience related to complementary therapies. So with that, I will happily turn the virtual mic over to Linda.
Thank you, Siri. Always a pleasure to work on a project with everyone at CFRI. So I have these three topics talking about complementary and alternative medicine, looking at prejudice, and looking at stigma. I'm going to start here and really give the definition and some examples. And I did get this information from the National Center for Complementary and Integrative Health. And starting here and understanding how we define CAM. And I know you all can read, so I won't read the slides to you. I will go through a process of highlighting various concepts and looking here and understanding that they're broken into, CAM is broken into two subgroups. natural products, and then mind and body practices when we're looking at them. And I like this graphic because it really does take a look at all the the different concepts when we're talking about complementary and alternative health practices, and being able to look at them across the spectrum. And always remembering that although some people use complementary and alternative interchangeably, that there are distinctive difference between the two. Alternative when used in place of conventional treatments, and complementary when used together with conventional treatments. And in my mind, optimally, when we can look at the opportunity to integrate them together and being able to come with a health approach that works for everyone. Next, I'm going to take a look at some concepts related to prejudice. The definition that I'm using here is from the American Psychological Association, because there are certainly multiple definitions that could be chosen, but I use this one for today, and wanting to look at the different aspects of ways in which we define and see prejudice showing up in behavior. And also looking here and looking at prejudice based on racial groupings, or groupings of people in different categories. And I want to highlight here this whole idea of any preconceived attitude or view, whether favorable or unfavorable. As an unconscious bias trainer, I have to spend a lot of time with people to help them understand that it's both favorable and unfavorable, because too often the conversation only focuses in on unfavorable, but not on acknowledging that in many cases there is the favorable and unfavorable side when we're looking at these concepts related to prejudice. And looking here at how prejudice shows up in healthcare, there's so many studies that help us understand ways in underestimation of pain and how that relates to racial bias, the dismissal of symptoms, primarily in the context of gender bias, and stereotyping compliance. A lot of issues there related to how we would define classism and what that's related to. Also looking at obesity and stigma that can be related to that and shows up in prejudice, LGBTQ discrimination, and ageism. Really looking holistically at ways in which prejudice can show up. And then going and looking at impact and understanding how prejudice can relate to poorer health outcomes, delayed care and mistrust, and poor communication. And I think that in this context, really being able to understand what happens with regard to communication and how that is showing up with regard to the implication of our behaviors as it relates to prejudice, and how that can hamper our ability to really be patient-centered with regard to care that's being provided. And looking at ways in which you can address prejudice in healthcare, looking at opportunities for standardizing care, and of course, implicit bias training, which I'm definitely an advocate for as someone who's really invested a lot of time, energy, and effort in training into being able to help people recognize, mitigate, and manage their unconscious biases. And then increasing representation and cultural humility. I often think that we don't talk enough about this context of cultural humility when we're talking about ways in which we can address prejudice and how that can facilitate our ability to do that. Next, to spend some time talking about stigma and looking first at the definition of stigma. And I want to emphasize that this definition comes from Conceptualizing Stigma, the paper that was written all the way back in 2001, but that still exists as the most, I think, comprehensive and specific definition that we can use with excellent examples of ways in which stigma is showing up. And I do want to take some time to break down all the components of stigma, because I think it's important to be able to understand all of these in the context of really grasping what stigma is and how it is different than other aspects, or it's different than prejudice or other terminology or issues that we encounter in this space. Understanding first the importance of labeling and labeling of human differences that matter socially. So not just labeling, but labeling human differences that matter in the context of our society and our social behavior. Stereotyping, linking that labeling and how it relates to negative characteristics in the context of the labeling, and how separation evolves, and this whole concept of us versus them, and how that relates to stigma, and the implications of it when we start talking about status loss and discrimination, and what those implications are for people. And the last concept, which always does not get addressed in the context of stigma, but I think is critical in understanding the impact and the effect of stigma, dependence on power differences, and understanding that it takes social, economic, and or political power to actually stigmatize in the context of our society. And the paper lists a lot of good examples of it, but I think that it's really important to help us understand this whole idea of the power dynamic that is part of the definition, and that it does provide multiple questions to ask that emphasize the way in which that power is demonstrated in our society. They do provide those here, and there's 2 on this page, and then 3 more on this, 2 more on this page. And being able to say the extent to which you can say yes to these questions as they're presented is how you really can get to the context of knowing and understanding that you actually do have a situation of stigma that's occurring. And then looking at understanding different ways in which stigma shows up in healthcare, and looking at interpersonal stigma, structural, systemic, and then internalized. So looking at it from all 3 of those perspectives. And also looking at specifically at CF and understanding those visible symptoms and public misconceptions that I'm sure you all are familiar with. And understanding this whole concept around invisible or misunderstood illness. And again, those are coupled together there in all of the misconceptions. Association with other illnesses in people's minds, the treatment burden and what that creates, and then the social and emotional impact and how that can be affecting people in the context of stigma. I wanted to just highlight this particular study from 2014, Assessment of Stigma in Patients with CF, and I'm assuming that some people are familiar with this particular study, but I really liked it because the focus groups, the group that they did, specifically said stigma emerged as a consistent concern during the focus group discussion. And noting and understanding here, talking about coughing, the misconceptions about CF, the lack of awareness, and the extreme reactions with regard to that. So I thought that was important in the context of a study that was done specifically in the CF context. And then talking about addressing stigma with self-advocacy, your opportunities to control the narrative, addressing the CF cough directly. There were a number of really good articles out there that talk about ways in which you can address that for yourself and ways in which you can help diffuse situations. Building support networks, setting boundaries at work and school, and then working with your medical teams and ways in which you can facilitate that, which I know we're going to do. Hanna is going to give us some great information about that, and looking forward to that discussion. I do want to take some time here to talk about traditional aspects of Chinese medicine, because there is a great body of work that references this in the context of stigmas that are related to it. And I think it's very relevant to the conversation that's coming. So racial and cultural bias that relates to it, and just these stereotypes that are related to it. Marginalization as alternative, and again, that gets back to the whole concept again of stigma and understanding that power dynamic that's part of being able to characterize something as stigma. The perceived lack of scientific evidence, regulatory and insurance hurdles, and historic prejudice that's existed for a long time and still exists today. And then here's another study, the physician's perspective on enhancing culturally sensitive care for ethnic Chinese patients. And I really liked this one because it did give you both summarized information from the physicians, and then it also includes observations and comments that were made by the physicians as part of the research. And being able to understand this whole idea of, in this case, many ethnic Chinese patients use TCM alongside conventional treatments, but often do not disclose this to their physicians because of the fear of the stigma related to it. And then looking at recommendations for improving care. And again, being able to offer formal education on the health benefits and TCM principles for healthcare professionals. And ending here with actual language from the physicians where they did talk about, they shared what they had actually communicated. They think it is, and looking at different cultural practices and how that related to their ability to provide care. And then one talking specifically about TCM and how people are approaching it and their responses to it. And one last set of quotes. And that is the material that I prepared for you this morning.
Next, we have the honor of hearing from Mao Vang. Welcome, Mao.
Hi, everyone. Thank you. My name is Mao, and as Siri mentioned here, I do live with cystic fibrosis. I was diagnosed not at birth. I am Hmong descent, so my parents are from Laos. They moved here in 1979 after the Vietnam War and had the remaining children here. So I come from a big family. There are 14 of us, and 5 of us have cystic fibrosis. I, as mentioned, was not diagnosed until around the age of 4 or 5. As some of you may be aware of it, CF in the earlier 90s into the late 80s was not tested, especially in like the Asian community. So even though my oldest brother was he was the first one to be not diagnosed, but had it and had some symptoms, it wasn't looked further upon. And then when I was born, I had a lot of health issues, as particularly breathing issues and all of that. But still, again, it wasn't tested. And so not until my sister was older, so there are 2 girls, me and my sister, and then 3 boys that have CF out of the 14 of us. And so we weren't tested until my 3rd sibling was really sick, and that was when they did some further testings and figured out that, the 2 of us had CF, so that if the 2 of us had CF, maybe the 3rd person might have it. And they did eventually test her when she was 12 and was determined that she had CF. However, after that, they still didn't test the remaining children until my youngest brother, until the second one was not feeling the greatest. And then they did test them later on and realizing that that 4th one had CF. So then they tested the remaining family members to figure out who had it and who was a carrier, who didn't. My baby brother was born in 98. And at that time, once he was born, because there were 4 of us that was diagnosed already, that's when they determined that he also had it at birth. And so, as we mentioned, I know we're talking about alternative and complementary therapies here. I wanted to share my experience, my lived experience, because I am Hmong, and so in the Hmong culture, we believe in shamanism. It's a belief of not just with the reality of what's going on today, but we believe that there's also a spiritual world out there. We also believe in our ancestors. And so growing up, my parents were very rooted in the culture and our religion and our faith in shamanism. And even though they knew that we were diagnosed with CF, they relied heavily on the doctors, but they also believed in shamanism, in the spiritual healing, and seeking alternative therapies such as like herbal medications that they could use to help us try to heal. At that time, what we do know now compared to what they knew back then in the 90s was very there's a huge gap. Being that in the Hmong culture, or in the Hmong community as well too, and I'm not sure if many of you are aware, but in the Hmong language, we are very limited in the words that we use to describe. For example, cystic fibrosis, we don't have a word for that, but we do have a word that we describe. It's a condition of the lung. So it may not particularly fully grasp the severity of this diagnosis. And even though at that time we had a translator, they were still very new to what CF was like in the Hmong community. Even when we were diagnosed, they were still really shocked that this family really had CF. They're Asians, and especially they're Hmong. And we were the first Hmong family to be diagnosed. And so they couldn't really figure out, like, how did this come about? This is not a very common condition or disease in the Hmong community. And so even though we had translators available at all of our appointments, there were words, or there were certain times that it may have not been translated word for word because of just how limited the Hmong language was with describing, or with the words that we used to describe certain situations or medical conditions. And so for my parents, growing up, the one thing that I do remember, and I mentioned to Sarah and everyone in the past, is that there was a lot of alternative and complementary therapies that they wanted to try, in addition to the doctors and what they were recommending. But it was not very welcome in the at that time. I think it was because of the lack of education, and one of the other one was because there was not a lot of research and studies of how CF would have impact a non-white person. And so at that time, I do recall, just thinking back about if we were sick, especially my sister and I were the two that were the sickest, and more often than not, we were hospitalized. And so with my parents having very little knowledge of what cystic fibrosis was, they relied heavily on the doctors, but they also relied heavily on their faith, on the ancestors, and on the spiritual world. They believed that sometimes if the doctors were treating us and we weren't recovering, there might be more of a spiritual issue than it is a physical or physiological problem. And so at that point, they would reach out to an elder or to a shaman to see if there's something that they can do spiritually to help bridge that gap. Or if, sorry, if they can pray to the ancestors to see if there's something that they have missed in the past, or if they were not doing something properly and the ancestors didn't approve of it, that they would ask for forgiveness and make a sacrifice. And so during that time of the grown up, the doctors had a lot of I think they approached my parents more from a fear based and not so much of a compassion based of how can we work together on this, but if you don't do this, we will do that. And so it did put us in a very tough situation. I do remember of my parents saying they will do it, and then when we get home we did something different for fear of getting in trouble by the doctors, or getting reprimanded by them. They didn't want to feel like they were disappointing the doctors, so they would say, we'll do whatever you guys want, and we'll do that only. And then when we get home, they will make their phone calls to like the shamans or the ancestors, or perform some rituals to the ancestors to see if there's something that they can do to help. And so I think the stigma in all of this is that at the time there was just a lack of education, the lack of knowledge, not understanding how, even though we are in America here, there are different, for us, different cultures and different beliefs that we come in from. And my parents were willing to work with the medical team, yet the medical team felt that they had this idea of how they really wanted to treat my family and I, especially my sisters and I, being that we were the two that were the sickest and often were hospitalized the most. And so as we got older, I know that my parents eventually did just tell the doctors, we've been giving you guys this many years to help treat them, and you haven't found a cure. You haven't been able to, make them any better. So at this time, we want to take over. We want to do our own things. And I do remember that was a big battle between the doctors and my parents, because they just felt that they weren't being heard, and that they were being misunderstood. They thought that maybe there might have been some voodoo or some black magic, or they were trying to poison us. They were buying stuff from the black market, which that wasn't necessarily the case. But I think the doctors probably were under that impression because they were not familiar with our culture and our belief, and how my parents wanted to try to do the complementary therapies in regards to, in addition to the Western medicine or the doctors that were doing their medications for us and whatnot. And so there was a lot of issues. And I know even with my youngest brother, unfortunately, my older sister did pass from CF. And I think once she passed, that really triggered my parents to put their feet down, to say that, we are at a point now where we've given you all the rights to our children to do whatever you want to do. And to date, you have not done anything to show us that you can help them beyond, what they say that they were able to do. And so they did start to take back in that reign of making the decisions for my siblings, the younger ones, and how they wanted to treat them. They just didn't want to have the doctors pump them with all these antibiotics or medications to see which one would work and which one didn't work, and then move on to the next round. So there was a point where I believe it was with my youngest sibling that eventually the doctors felt really passionate in their belief, and that at one point they did say, if you didn't do this, we would get child protection involved. So I think there was that threat of getting child protection involved, and getting a lot of legal paperwork in place to kind of make sure that they do what the doctors wanted them to do. And all my parents wanted to do was try these complementary therapies, whether it's with the doctors in the hospital when we were in the hospital, or to let us go home, try this for a week or two and see how this works. And then if it doesn't work, they will bring us back. And so they really worked with the doctors, but unfortunately we didn't quite have that receptiveness from them because of, again, just the lack of education, and I'm not sure what else it was from their end, but I do. So that's where my lived experience has come in, from this of hoping that in the future we can be more open to this. I don't know if many of you guys have read the book, When the Spirit Catches You and You Fall Down, but that talks a lot about, the Hmong culture and how the little girl in there has epilepsy, but it also clashes with modern medicine and what the parents believed in. And it does a great job of describing just the stigma and how they wanted to treat the child. And that reminded me of our situation of just how growing up, as great as the doctors were trying to help us, just the operation of fear instead of compassion and wanting to learn, and researching more about it really did also affect us, because as children, we also felt kind of torn. Like, do we do what our parents say, or do we do what the doctors say? Because the doctors were saying, if they were saying, sorry, because there's a lot of, you don't do this, you're going to die. And I think that part, as a kid, when you grow up, you hear that all the time. It's really fearful, because then now it's like, oh, if I don't do what my parent wants, I'm going against them. But if I don't do what the doctor says, I'm going to die, so I can't see my parents and I can't see my families. So what do I do? And I think as a child, you just try to do your best to make it work between the parents and your doctors. And whenever they see you, they're like, well, did you do this? Did you do that? And, I'm not going to lie, I lied a lot because I was confused. I lied a lot because I didn't know, I didn't want my parents to get in trouble. But I also didn't want the doctors to be disappointed that I didn't do what they wanted me to do. So I think just now as an adult, looking back on that and wishing that we had more support from social workers, from the medical team, and just helping us understand that, even though at that time they didn't have a cure, it wasn't necessarily that if you didn't do this, you were going to die, but that, we could do our medications and stuff together, and we could work together as a team instead of us versus them. And if you don't do this, we're going to send child protection out to you, or we're going to take your children from you. And so that really, unfortunately, put a big armor up with, especially with my parents after my sister passed, of not wanting to be forthcoming. And they did really withhold the other two younger ones from the doctor, not withhold, but they didn't feel the need to really bring them forward all the time to the doctors, and instead did try more of complementary therapies at home. We did a lot more herbal medications, such as lemongrass and ginger. We did a lot of herbal roots. We did ginsengs. We had a lot of grassy leaves, the sweet flags. We just did a lot of those herbal medications at home in the meantime to to see if that'll help. And even now, I still do some of them, even though the doctors I know do say there's not a lot of research about it. It has worked for us for many years, so we have continued to do it. And it is my hope that in the future we can educate more of the medical world about not just limiting to what modern medicine is, but understanding that there are complementary therapies out there that can really help, especially for families that are not just rooted in Christianity or the American world. That even though I'm American, we still have our own faith, we still have our own belief, our own culture that we want to follow, we want to honor, and we want to do that. And we just want a safe place so that we can all work together as one instead of doing it to feel like we're hiding and then we're lying. And it does cause a lot of problems because I've seen it with my own health growing up and in my own family as well too. Of I lied a lot as I got older to avoid any situations or any problems with my doctors. And so I know that now I can be more forthcoming. I can put my foot down and really say, no, this isn't working. I need to consult with my parents first, or I need to consult with the elders. We need to do our rituals before we can move forward with this. And, it is very liberating to be able to do that. But growing up, that was unfortunately a very bad timing for us, and such an experience that sometimes it can still be traumatizing because it brings you to a place where you don't want any child to be at. You don't want to have them choose between their parents or the doctors. You don't want them to feel like, if I don't do this, I'm going to die, so I can't see my family. So that's the one thing that really lived in me that I'm trying to move past. But thank you all for being here.
Mao, thank you so much for sharing your very personal story. And I know all of us are feeling, we all want to just give you a big hug, and also sharing your outrage for what you and your family have gone through these years. I mean, trust was utterly broken between you and your care team, your parents and the care team. So between Linda and Mao, your personal experience laid the groundwork perfectly for Dr. Hanna Phan to take over. So I'm just going to quickly turn the mic to you, Hanna. Welcome.
Thank you, Mao, for sharing your story. I know it takes a lot to be able to share something so personal, but I know that it'll hopefully positively impact care teams to be more mindful of their approach to care. And thank you, Linda, for your setting the platform for everything. And thank you, Siri, for the kind introduction. I kind of want to go over today being more interactive. So if you have your cell phones in front of you, you can participate with this, hopefully this QR code. We'll do some word clouds. I kind of want to hear about what your perspectives are on patient-centered care and shared decision making. And then we'll have a conversation about like best practices of what clinicians should be doing as part of that partnership between patient, family, and clinician. So you'll see this QR code pop up again with future questions. But I kind of want to get a feel for our audience today and our group that's collected together, which best represents you. If you can mark that would be great. Awesome. We have great representation across the board, from care team members to persons who live with CF and caregivers, as well as others who are part of this great community. All right. So I would love to know, for you personally, what does person-centered care mean to you? I see a lot of individualization, joint decision making, care, taking time to see and hear the whole person, focusing on the person in front of you, very important, listening to the patient's voice, care that's specific to me and my needs. So the biggest things here are care and individualized. It's picking out the biggest words and themes from the conversation right now. All things that should be part of person-centered care. And it sounds like a lot of common themes that are coming about from this, which is great. Listening, individualized, focused on the patient, respect, having a joint decision-making process, and focusing on that person in front of you. So there are a lot of various components to patient-centered care, but these are the big things and takeaways from a lot of the literature that is, describes patient or person-focused care or person-centered care. So you have your person with condition, say a person who lives with CF, and it should consist of at the bare minimum these components. The communication between clinician and the person should be clear and understandable. There should be dual dialogue, transparency in that dialogue. There should be cultural humility of that clinician, because we don't know everyone's culture and background, but we should be able to respect it and be able to be open to hearing about it and learning about it. Being responsive to their preferences, values, beliefs, and goals. That's going to be weaved into shared decision making, which we'll talk about. And of course, of utmost respect and dignity for that culture, humility, and having that dual conversation with the person in front of you. So as part of patient-centered care, we should be practicing as clinicians shared decision making, otherwise known as co-production of care, which I think we hear a lot in the CF community. And at minimum, it should involve the person with CF and the clinician. But that bubble is not just a singular bubble. It could include their caregivers, family members, religious members that may be contributing to decision making, as mentioned with Mao, and elders and shaman in terms of advice and integration of their opinion. And that shared decision making should be respectful, have a duality of questioning, like curiosity questioning, honor, respectful questioning, as well as shared information. And then discussing the various options very thoroughly, hopefully allowing enough time to do so, which I know is a very big challenge in clinic visits as we're limited on time sometimes. Weighing the risks and benefits of each option. And while doing so, integrating the person's goals, their values, preferences, and circumstances as part of those options that are available. And so what do you feel limits the optimization of both patient-centered care and decision-making in your experience? What things have you seen or experienced yourself that you feel like, man, this could have been better, but this is the reason why, or the barrier that maybe the reason why it didn't happen? I'm seeing a lot of stereotypes, for sure, pride, unfortunately, insurance, unconscious bias is a big one. So if you're seeing the word cloud, the larger the word, that means more people have said this similar theme or term. Time, which is very limiting. Provider thinking they know best, and we do not. We don't live the experience, so we should not be the one that knows best. Cultural competency or lack thereof, right? Um, so a lot of different components for sure. Let's see here. So a lot of bias, time, standards of care. And oftentimes I think we as clinicians, when we think about the standard of care, like it's a black and white end all be all, this is what has to happen. But remember that with person-centered care, it's individualized to the person. Yes, we apply evidence, but does that evidence always apply to that person? And I'll talk about one aspect to really consider, especially when it comes to the evidence that we're using to support our recommendation for therapies and things like that. So you guys gave some great examples of potential barriers, and I'm sorry if those are things that you've experienced yourself or seen yourself. Limited appointment time, number one thing. We're in and out all the time with clinic visits. There's only so much time per visit. Providers are now being asked by insurance to see so many patients a day, etc. The use of medical jargon, kind of blurring the lines quite a bit versus clear communication that is at the appropriate health literacy of the person in front of you. Limited awareness of the clinician regarding cultural differences, patient fear of judgment, lack of clinician awareness of where they stand in terms of transparency and being aware of cultural difference and their perspective and values. Clinician fear of the unknown. Some clinicians respond and react in a way in which it's more of like, I'm not sure what that is. I don't want to touch, like, let's not go there because I don't know what that is, which is, not appropriate. Mistrust of the healthcare system. Our patients will face this and they may not always voice it, but it may be underlying and we may not seeing it or detecting it. And we need to address that. Cost or insurance coverage, which is a big one. Limited health literacy, and then misinformation from sources. We can get so much information from various places now with AI and everything. What is trustable information? What is accurate information? So remember that both on the, especially on the clinician side, we need to remember, but also for patients, to remind your clinician partners that treatment decisions are preference sensitive. Yes, we can tell you what is best based on what is in the evidence, but we also need to make sure that we're recommending things that are in line with your goals, your values, and ultimately will help you and benefit you and engage you in your care. So, modern medicine, I apologize for the typo, versus cultural health practices, benefits versus side effects, deciding between symptom control and medication burden. Yes, if we add more therapies, it may help your symptoms, but it's also adding medication burden to your day-to-day regimen. Cost versus convenience, making, the preference of prescription medication or modern prescriptions versus complementary alternative medication. The viewpoint of short-term relief in your condition, but worrying about long-term safety of a newer medication that may be on the market. And then one that I have experienced before is where a patient and family has brought up to me before, yes, you say that this medication works for people with CF, but when I look at the data, and this was a very informed parent, when I look at the data and I see the demographics of people included in the study, it does not represent my child. So how do I know it's going to work in my kid or the side effects won't affect my kid? So keeping these things in mind as we're partnering to make decisions. So what I would like to know across our community today, how comfortable are you about discussing CAM or traditional cultural remedies in clinic visits? So 1 star is not at all. 5 stars, totally comfortable, willing to discuss it. All right. So kind of in the middle at a 3.6 on average of those who participated in the poll. That's good. So hopefully conversations are happening and open discussion is important because having that not disclosed or feeling like you have to hide it. I never want my patients or families to ever feel like they have to hide anything from me. I want to be able to know what's going on so that I can best help and support. So as a pharmacist, I'm going to have to talk about medication histories because that's something that is near and dear to part of our practice because we want to make sure that we have an appropriate and accurate history so that we can best help in terms of determining any recommendations for changes as well as monitoring for safety. So traditionally, I've seen in various practices the limited time that is probably the big rate limiting step in terms of doing a comprehensive medication history and assessment. But it should include the following. Of course, prescription medications, and not just a matter of are you taking it yes or no, but how's it going? And if it's a new medication, have they started? If they haven't started, what are the reasons? What help me understand why the medication hasn't started? Do you have what concerns and questions do you have? Over-the-counter medications, vitamins and minerals, herbal products, any other supplements, traditional and cultural remedies. It could include a tea that is coming from a certain root or a powder. Teas, tinctures, powders, oils, or other topical products that maybe not of the above. The use of cannabis or even like cannabinoid products or CBD, as well as assessing and inquiring about medication access. Some patients and families may not, some folks may not be comfortable saying, I can't afford this medication. I haven't been able to get it because my car is broken down. I can't get to the pharmacy. But giving that open space to be able to share that information so you can best help them. Including adherence, asking about any questions or concerns, having an open forum, like, I want to know, like, if there's a side effect, I got to know about it so I can help you manage it. Or if you haven't started medication, let's talk about why and how I can best help you. And always asking without judgment. So if your clinic, I would like to know your clinic experience, both as a person with CF, caregiver of a person with CF, or a clinician. What's your general approach when it comes to CAM, like herbal supplements or something that's taken or applied or inhaled or what have you? Is it not assessed? So there's really not an approach to it. It's assessed, but we really say no to it. Assess on a case by case and assess safety components and co-produce a plan. Or do we allow for use, but we really don't add any additional monitoring, but we want to be aware of it or other, I'm not sure. So it's a mix of different approaches. Some folks aren't sure what the approach is in their clinic or maybe haven't encountered it yet. And some don't have an approach yet, not assessed, not monitoring. Some are not monitoring, some do a co-produced plan. So it's a variety of different approaches here. So as a person with CF or a caregiver of a person with CF, some things to kind of consider if you're thinking or contemplating use of complementary alternative medications. One and first and foremost is the supplement safe and beneficial. What information have you received and what have you heard about it? Talking about it with your care team, of course, if you can, if you're comfortable. And remember that supplements are not permitted to be marketed for the purpose of treating, diagnosing, or preventing or curing diseases. That's just a disclaimer from like an FDA standpoint. And be careful in terms of the marketing that sometimes is listed. I will say that if claims are too good to be true, that sometimes it is too good to be true. So just be careful. There are predatory folks out there who want to take your money sometimes for certain reasons, which is cruel and inappropriate. When searching for information about a particular supplement or ingredient, make sure that you're using non-commercial sites that aren't tied to the sale of that product, but rather things like the National Center for Complementary Integrative Health that Linda had mentioned before, instead of going to the seller for that information, because they're going to promote their product and tell you what you probably want to hear. And remember that just because something is natural doesn't always mean it's safe. It can still interact. Natural products are medicine, and they can interact with medications, they can interact with your organs and systems. So we just want to make sure, again, having a dual conversation and planning accordingly for safety. So for my fellow clinicians, like some recommended practices or approaches in terms of how to approach the conversation. Here are some suggestions in terms of how to approach it. Like some people use herbal or traditional products along with prescribed medications, and we understand that happens. I ask everyone about this because it helps me keep you safe. So if I know about it, I can help and partner with you with monitoring it. What are you hoping this product will help you with? How often do you take it? Have you noticed, benefits or side effects? How long have you been taking it? And would you be open to reviewing like a possible plan to monitor for safety down the road, like additional labs or things that we can test for? As a clinician, we want to consider things and not just block off and say no. The easiest way to lose trust with your patients and families is to say absolutely not, you can't use it. Partner, have a conversation, learn more about it. Ask about how they're taking it. Is it inhaled, oral, or is it topical? How much are they taking? How often is it being taken? Is the person willing to try a lower dose if we know that the ingredient in it could be potentially harmful for liver or kidney function? Look into the product purity, look into the actual product that they have. If the patient family can bring it into clinic, you can look up where it's coming from, making sure it's coming from a reliable source. Looking at both ingredients that are active ingredients as well as inactive, because both can actually cause effects in the body physiologically. And thinking about the potential effects of those ingredients and the options for safety monitoring. So what can we monitor? What's feasible? And talking with the person in front of you and asking them, goal-wise, what would you like to achieve? Are you willing to partner with me to monitor for safety? Because I'm working with you to do modern medicine plus your traditional medicine, but let's partner together to make sure it's safe. So looking at drug interactions, effects on the livers or kidney, any bleeding risks with medications or effects on electrolytes, blood pressure, or blood glucose. And this is my little plug as a pharmacist. Consult with a pharmacist if this comes up, because they're a really great resource to look all that information up. Doctors are limited on time sometimes. Clinicians are limited on time. So if you have a multifaceted, multi-interprofessional care team and you have a pharmacist on that team, that is their area of expertise. Let them contribute that way. What about traditional cultural healing practices like prayer, integrating practices to appease ancestors or to ask ancestors for help? What are the practices that you've seen in your clinic, if assessed at all or asked about? So I would imagine this was probably less asked about, unless it's part of usual practices and built into protocol. But it should be something that we talk about. It's part of a person's cultural identity, a part of their health beliefs. And so the more that we can know about and learn about and understand about the person in front of us, the best we can help partner with them and come up with the best plan. So beyond the herbal products and supplements, when we're talking about cultural healing practices and remedies, it may include things, traditional healing can include anything from like physical, herbal, spiritual, and family-centered practices. I'm not sure if anyone on our call today is familiar with coining. That's often an East Asian practice. I know my parents did it when I had a cold, but then if you went to a physician and they saw that, they would be very shocked and worried about child abuse. I remember once my parents had to explain that to a physician when I came with a cold, and they were like, "What is this striping on her back?" And I still remember that conversation. Massage, spiritual healing and prayer, soul calling. There are some practices in which there's strings that are tied of a different color to ward off different spirits or evil spirits and things like that. Health decisions may not just be for the person of CF to decide. They're caregivers. It may involve elders, family members, spiritual healers, for example, and being able to be respectful of that and integrating and being together so that a decision is shared. So some things to think about in terms of best practices, if for my clinician colleagues out there, when it comes to traditional healing practices, being open-minded and wanting to learn more about it. So many people will use different home remedies, traditional healing, etc. Are there any healing practices or remedies that are important for us to know, that are important to you, so we can help support you safely? Remember that the goal of inquiry is not to shame the person in front of you or the caregiver, or not to even approve or disapprove right away, but to best understand what the practice is, what they're being used or being considered, and why. So with that, I'm providing you like a brief framework for shared decision making. As clinicians, I invite you guys to invite the person in front of you into that decision, not just coming in speedily and be like, all right, we got this, this, and this. Which one are you most comfortable with? We're really going over, we have options. I'd like to know what fits your goals and we can decide together. And then as you're going through the different options, making sure to go over what the benefits are, what the potential risks are, and when you may expect to see those side effects, and how to monitor for them. And coming up with a plan together on when to monitor things and when to report them. And then discussing, giving that open forum for questions and answers. Giving that time for family members and the person in front of you to ask questions and express their concerns about the options that were presented in front of them. And then once you've discussed all of that, hopefully coming up with what options are most acceptable for you and that meet your goals and values. To close, like patient-centered care starts with reaching out with compassion, empathy, and with effort to understand the person in front of you in terms of their goals, their values, their culture, and daily life. Shared decision-making, make informed choices, help the person in front of you make informed choices and best align with their goals, again, preferences and values. And being open and empathetic in terms of inquiring about different complementary treatments, traditional health practices. It should be part of our practice and a traditional practice routine care, but especially at medication review. And remember to always apply a non-judgmental approach. It can help improve the sharing of information, improve safety and partnership, and that treatment decision and plans should be revisited with your patients and with your clinicians based on the needs of the person in front of you and whenever their circumstances may change. So one thing I want to ask of folks today is think of a medication conversation you may have had with a clinician or with a person with CF in front of you. And think about, what is one question that could have been asked differently that could be more person-centered? And then this is the final takeaway for me. Better medication decisions happen when both clinical evidence and the patient experience meet in that same conversation. So with that, I'm happy to take questions. My contact information is listed here, and I thank you guys for your time.